Hi guys, welcome. Today we're going to be talking about shock. And shock, this is circulatory insufficiency and becomes irreversible if it is not promptly corrected. So you have different types of shock. We have hypovolemic shock and septic shock. So hypovolemic shock is due to loss of intravascular fluid volume and results from blood and or fluid loss due to decreased circulation of blood volume, leading to decreased diastolic filling pressure and volumes. So this can be caused by hemorrhage, severe burns, so rapid plasma loss from damaged tissues when over 25% in burns, and endotoxemia makes it even worse. So dehydration can also lead to this. Vomiting and diarrhea in cases of cholera and enterolitis. We also have septicemia and intestinal obstruction can be mechanical or paralytic illness. So clinical features, how is the patient going to present? So clinical features, the patient becomes cold, clammy, drowsy, and tachypneic. So this is cold, sweat, and restlessness, and blood pressure may become unrecordable. So the skin is pale and cold with collapsed peripheral veins with tachycardia. So the urinary output is an indicator of renal blood flow and will fall significantly over time. And temperature is subnormal, usually less than 35 degrees. So what investigations are we supposed to do in such a scenario? So we have to do a HB, we have to do urea and electrolyte levels, blood sugar. We also have to do groups and cross match of the blood. We have to do also blood gas analysis. If it's possible, we also have to do a blood culture. After this, we have to manage the patients. And once shock is suspected, the person attending to the patient should initiate appropriate and coordinate emergency management of the patient. So here we have to treat the primary problems such as control hemorrhage and endotoxemia. So you also have to secure a large intravenous line need to cut down if there is no accessible peripheral line. You can put a central venous line. So you have to start infusion with isotonic saline, that is normal saline, or run for 2 liters fast in an adult. So gross and cross match blood before you give any plasma expander. So plasma expanders help cater for the blood loss in the system. So transfuse in case of blood loss. Burns due to shock. If shock is due to vomiting or diarrhea, you can replace by continuing fluid loss by giving normal saline. In adults, we give 1 liter 6 hourly of Hartmann solution or even normal saline. You continue with the IV fluid until shock is reversed and cause is treated. So closely you have to monitor the vital signs. You also have to monitor urinary input output. You also have to give a broad spectrum antibiotic if septic shock is suspected. So you have to continue maintenance until shock is reversed and cause is also reversed. So surgical interventions can be undertaken as soon as the patient is stable, such as a laparotomy if the cause is intestinal obstruction. You also have to give a broad spectrum antibiotics for sepsis and patients who have had burns. So straight up, we go to septic shock. And in septic shock, clinically, the patient uh, is going to present a bit differently. So systematically, the sepsis resulting to hypotension or multiple organ failure. So initially warm shock, and then increased heart rate presence, diaphoresis, then warm skin, then later cold shock. So this is decreased cardiac output and cool vasoconstricted skin. So complications may come like pulmonary edema, renal failure, disseminated intravascular coagulopathy, DIC. And here we have to do certain levels of investigation such as HB levels, WBCs, check out the platelet levels, urea and electrolyte levels, creatinine, blood sugar levels, culture and sensitivity for both blood and body fluids. How do you manage this patient? So generally, resuscitation with normosaline and dextran, which is a plasma expander. So large volumes may be required, but to watch for heart failure. Here you also have to have a CVC. So in addition, you have to monitor pulse and BP hourly. You also have to catheterize so as you can be able to monitor urine output hourly. So if it is less than 20 mils per hour after adequate fluid replacement, then you have to give furosemide 80 milligrams IV start so that the patient does not have fluid overload. So you also have to give oxygen via face mask and determine any definitive course so that you can be able to treat. Pharmacologically, how do we manage this patient? So, first of all, you have to start this patient on an antibiotic, preferably ceftriaxone 1 gram IV once daily or benzyl penicillin 4 mega units IV every 6 hours and gentamicin 80 milligrams 12 hourly. With adequate fluid replacement and close monitoring of urea and electrolyte levels, you also can give metronidazole 500 mg IV 8 hourly or hydrocortisone for any allergic reaction 200 mg 8 hourly for 24 to 48 hours. You also have to give vasopressor such as dobutamine, dopamine, and adrenaline as if there is any indication for one to administer. So you also have to commence oral medication once the required course of IV antibiotics is completed. So choice of antibiotics depends on the source of infection and culture and sensitivity as a result. Once the patient picks up, it's very important for us to do counseling for the patient so that it helps in recovery of the patient once they become stable. Also, always anticipate for onset of disseminated intravascular cardiomyopathy. Thank you. I hope you've learned something about shock, and I bet you can be able to manage our patients way much better. Thank you. Have a nice day.